Chapter 38, GI Part 2, will continue with gastroesophageal reflux, or GERD. Okay, so you can see right here that sphincter is just not doing what it's supposed to, and that is why this contents are going back into the esophagus. They're spitting it out. Here it should tighten just as this shows. So it hits that, but it goes back down. Here it's wide open and goes straight up. Children should be tested for a milk protein allergy, since there is an association between gastroesophageal reflux and cow's milk allergy. So before we diagnose a child with GERD, we want to make sure that it isn't something as simple as a milk allergy. So we'll remove milk from their diet. If they're on a formula, we'll make it a lactose-free, dairy-free formula. Okay, so nursing diagnosis, they are at risk for aspiration, deficient fluid volume, they're not taking in enough volume, which can also make them at risk for dehydration, imbalanced nutrition, and risk for infection. The treatment is going to depend on the severity of the disease. They can try some antihistamine 2 antagonists like the Xanax. They might try some PYLORIC, something like that. However, if that does not work, they might even have to go in and do surgery. And you can see on page 843, figure 38.4, a picture of what that surgery would look like. They actually take the stomach and wrap it around the esophagus. Uncomplicated GERD may require lifestyle changes, including small frequent feedings, adding rice cereal just to give it a little bit more bulk, a little bit more weight, to thicken up those feedings. Feeding smaller amounts with frequent burping, holding the infant in an upright position for 20 to 30 minutes after feeding, burping frequently, positioning, maybe every half ounce to an ounce you are taking the baby off the bottle and burping them, repositioning them, doing kind of this hula hoop maneuver where they're on their bottom and you're just moving them around, kind of trying to facilitate gastric emptying. There are proton pump inhibitors, antacids, histamine antagonists that are all used as well. Protonic, Xanax, PYLORIC, just to name a few. And then of course surgery may be indicated for children who do not respond to treatment. Colic. If you've ever had a colic baby, you know what we're talking about here. Colic is abdomen pain of intestinal origin and severe crying. It's very, very uncomfortable for the baby, very uncomfortable for the parents. No one ever wants to see their baby crying. And though you try everything in your absolute power, it just doesn't seem like anything works. We don't really know what causes it. However, it usually does occur between 2 to 6 weeks of age and generally subsides by 3 months. Of course, this isn't much comfort to the parents who are trying in that moment to get the baby calmed down, but they do need to know that it is temporary and it will eventually go away. It may be due to feeding too rapidly, swallowing large amounts of air. The infant just cries continuously for several hours, face is flush, abdomen distended and tense. It seems like their tummy is hurting. They can drop their legs and clench their hands, and the cry may only stop when the child is completely exhausted or after passing gas or stool. A lot of times you'll see parents trying to do every kind of comfort measure, from driving them in cars, wearing front swing wraps, holding them on the front of them, whatever they can, carriers, all of it, peppermint water, we've heard it all. However, you do have to remind them that it will eventually subside. We also need to look at a history of the infant's diet and daily schedule and events surrounding these episodes of colicky behavior. Could it be something that the mother took in as she was breastfeeding, or could it be the formula is just not settling well with the baby? We're assessing the infant's feeding patterns, including type, frequency, and amount of feeding, assessing the onset, duration, and characteristics of the cry, and what's used to relieve that cry. Teaching parents rhythmic movement using that front carrier slings or infant swings or car rides. swaddling the infant, placing prone in parents' arms, respond to crying with soothing voice, and prevent loud noises, pacifier, warm bath, massaging the abdomen, feeding small amounts, burping frequently, holding the child upright for 30 minutes after the feeding, and also just teaching the parents, if it does get out of hand and it's too much, that it is always okay to place that infant in the crib where they're safe, no toys or anything in it, and just letting them cry it out a little bit, and you taking a 10-15 minute break away from that child and regaining your composure as well. The worst thing you could do is to shake that baby. So always reminding parents it's okay to step away, and the child will be safe, they'll be in the crib, and no child ever died from crying, but a lot of children have died from abuse or shaken baby syndrome. So letting them know that it is okay to step away. Okay, diarrhea and gastroenteritis. Gastroenteritis is diarrhea, but it's the infectious form of it. Often it is caused by E. coli, dysentery, rotavirus being the leading cause in children. It's transmitted by fecal-oral route, fever and vomiting for 2 days, and watery diarrhea for 5 to 7 days. Now with kids, it is very, very important that they do not get dehydrated. They can get dehydrated as quickly as in 3 days with diarrhea. So that is why we're watching it and making sure it doesn't go to a severe form. Diarrhea can cause children to become quickly dehydrated, like I said, at risk for hypovolemic shock. Fluid electrolyte losses must be replaced. The imbalances can occur in disruption of acid-base balances. The diarrhea can be anywhere from mild to moderate to severe. Hand washing is going to be the most important measure that can be taken to prevent the spread of gastroenteritis. Okay, when we're doing an assessment on a child who has diarrhea, we need to know the history of the illness, the onset, the frequency, the color, the amount, the consistency of stool or emesis, and the exposure to illness. Any kind of antibiotic therapy, travel, food, formula preparation, allergies, and of course assessing pain. We are nurses, and we are those weird individuals who like to know about people's poops, and we want to know everything about it, even including the way they smell. It seems strange to parents, but we need to know. And there's a reason we need to know as well. We're not just weirdos. Assessment of child's hydration status is going to be your highest priority. Planning, prioritizing care, nursing interventions are going to be focused on assessing signs and symptoms of dehydration. And knowing how to know if your child is dehydrated. Signs and symptoms of dehydration. The child may not urinate for 6 hours or more. They might not have any tears when they're crying. The child's mouth will be dry and sticky to the touch. It won't be moist. The child's eyes are sunken in. They're less active than normal, and they have dark circles all around their eyes. Of course, we're also going to be weighing the child on admission and using a daily weight, same scale, same time of day, same amount of clothing. We'll be monitoring, documenting eyes and nose hourly, weighing each diaper, making sure that they do get at least a diaper in 6 hours or more, and that they are urinating at least every 6 hours. Child's usually going to be NPO, and that allows the bowel to rest. Oftentimes you'll find that children won't want to actually eat. With vital signs, you will not probably do a rectal temp on a child who is having a lot of diarrhea. One, it can cause them to have more stool, and two, it can irritate that sensitive skin at that time. So more than likely, if they're having diarrhea, we are not going to do a rectal temp. We'll do axillary or different means depending on how old that child is. Talking about boluses, you may have to do some IV fluids, and a bolus may be needed for that child. The amount would be 20 mils per kilogram per dose for that child. So if that child's 10 kilograms, you're going to times it by 20, do the math, 200. that's the amount of bolus that child would need at that time. You want to begin oral rehydration with frequent small feedings using products such as Pedialyte. You'll be monitoring their lab results, practicing standard precautions, good hygiene, good hand washing. Pyloric stenosis results when the circular areas of the muscle around the pylorus are hypertrophy and block the gastric emptying. So you can see it's at the end of the stomach and it's right here and it's just narrowed. The food is not able to pass into the small intestine. Exact cause unknown. Usually symptoms are evident by 2 to 4 weeks of age. And what you're going to see with this child is that they are ravenous. They are so hungry. There isn't anything wrong with them except that they can't eat. And so they don't feel sick. They want to eat. Even after they vomit, which you'll notice that the vomiting is very forceful. It's projectile in nature. It doesn't have any bile in it. It may be blood tinged due to esophageal irritation, but no bile because it's not getting down into the intestine. They will spit that up, but as soon as they spit it up, they are hungry and they always seem irritated. They can't gain weight, and eventually they'll have fewer stools because the food is not passing into the small intestine. You will see visible peristaltic waves noted on their abdomen, and you'll even be able to feel a palpable olive-sized mass in the upper abdomen. Hyperactive bowel sounds on auscultation, and as the obstruction progresses, the infant becomes dehydrated and the electrolytes are depleted, resulting in a metabolic imbalance. Of course, you want to assess for dehydration, assess the skin turgor, fontanelles, urinary output, mucous membranes, all to determine that hydration. Surgical correction is the treatment of choice. IV fluids will be given for rehydration, nasogastric tube inserted to decompress the stomach, and then they'll go in and they'll actually make that pyloric a little bit larger so that food is allowed to pass. HIRSCHSPRUNG'S disease. HIRSCHSPRUNG'S disease is also known as Megacolon, and it is a congenital anomaly which inadequate motility causes mechanical obstruction of that intestine. It prevents peristalsis at the portion of the intestine, which results in accumulation of intestinal contents, making that intestine very large, causing the abdomen to become distended. It's often more common in boys, can occur alone or in combination with congenital heart defects and Down syndrome. So you can see where this bowel becomes large and inflamed. Assessment finding: newborns fail to pass the meconium, they have abdomen distension, emesis. Older infant may fail to gain weight, have severe constipation, and the history may reveal passage of pencil-thin stool. It's always important to know what their stool looks like. Treatment in severe cases will include surgical removal of this infected or the large bowel, and could possibly end up with a colonostomy. Treatment in mild cases may be dietary modification and stool softeners. Intussusception occurs when one portion of the intestine prolapses and then telescopes into the other. So you can see in this picture where part of the intestine is actually going back into the other intestine. Most frequent cause of intestinal obstruction during infancy. Cause is not always identified, but could be viral infections, gastroenteritis, medications that enhance gut motility, kind of like your protonics. And the body's inflammatory response may be associated with intussusception. Onset is usually very abrupt, with acute abdomen pain, vomiting, passage of brown stool, and then it kind of becomes red and resembles more of a current jelly stool, mucus and blood. And that's as it gets a little bit worse. It's very painful, and cardiac signs, you could have shock, vomiting, and those current jelly stools. Contrast enema using barium, air, and water-soluble contrast may move the bowel back into place. Doctor can feel a sausage-shaped mass through the abdomen wall, And if it's not resolved, then the child will have to go to surgery.